Conversations that chronicle medical discoveries, hard to diagnose illnesses, and other relevant health topics straight from the experts. Welcome to Documentaries. More than 100 million people have been infected with COVID-19 globally. Of those cases, the Philippines accounts for about upwards of 500,000 infections, while 91.7% of those have recovered and only 2% of those have died. Billions of dollars in resources were invested in developing those vaccines at pace. But what if these will only go to waste because people don't want to be vaccinated anyway? Today, we're going to learn from Dr. Carl Henson, the Director of Hospital Infection Control and Epidemiology Center and Chair of the Antimicrobial Stewardship Committee of the Medical City. He is also a Clinical Associate Professor of Philippine General Hospital's Section of Infectious Diseases. He is immensely passionate about over-communicating this topic as he juggles his public education initiatives with his master's degree in public health in the University of London. You've probably seen him in every credible webinar on COVID-19 since the start of the pandemic.
To help us understand, we now talk to Dr. Carl Henson.
Welcome to the show, Dr. Henson. Good morning, Dr. Henson.
Have today with us Dr. Carl Henson. Doc, good morning.
Let's hear from Doc.
Hi, good morning.
So, Dr. Carl, how do vaccines really work?
How do vaccines really work? The main goal, the main purpose of vaccines is to induce protection in the person who receives it. And the way it happens is the person is exposed or given either the entire virus or pieces or particles of the virus. And these pieces or particles then induce what's called an immune response. So, for example, if you get sick with chickenpox, so the chickenpox virus is in your system, and then the body starts to memorize this virus, and it will start to produce protection in antibodies against chickenpox, so that the next time that you get exposed to chickenpox, you no longer develop the disease. So instead of you getting sick, when you get the vaccine, you get the protection from that disease, without having to expose yourself to the complications of getting the infection.
Having said that, so are all the COVID vaccines created that way?
I guess we need to sort of think about first what are the different kinds of vaccines in general. So there are many different kinds. You can give the entire virus, either weakened or dead, but the entire virus. So that's called a virus vaccine. That's the first one. The second is protein subunit. That means either they create pieces of either the wall or some other piece of the virus or bacteria. They package it into the vaccine and give it that way. And this induces an immune response. It's also possible to give pieces of DNA or RNA. These DNA or RNA, they're packaged in lipid-coated things, and they're given to the patient. They enter the cell and produce the proteins that way, and the proteins induce the immune response. And then the fourth one is what's called viral vector. So they take a harmless virus, put a piece of the virus or bacteria there, the genetic material, and then given to the patient. And then the protein is produced that way. So the end goal of all four really is to produce substances that will trigger the body's immune response to induce protection. Now, the COVID vaccines, Pfizer and Moderna, they are mRNA vaccines. The AstraZeneca vaccine, and the Gamaleya, yung Russian vaccine, Sputnik 5, they are adenovirus vectored vaccines. Some of the other ones, like Sinovac, they're inactivated, meaning they contain the virus, but the virus is killed and given to the patient, and then you get the immune response.
When you said RNA and it will enter my cells, does it really mean that it will alter my DNA?
In the human body, the most important genetic material is the DNA. This is the core of our being. And it is contained in each and every cell of the body inside a compartment called the nucleus. the mRNA vaccines never enter the nucleus of the cells. So they do not mess around with the DNA. So it's not incorporated into our body. It just really is translated very simply in the cytoplasm outside of the nucleus. So it doesn't.
But even if it won't alter my DNA, will I still feel some changes after I receive the vaccine?
We then need to think about the concept of reactogenicity to answer that question. No? Reactogenicity is a term that refers to the physical manifestations of the immune response. So, remember, you're giving foreign agents, foreign bodies into the patient. They're safe, but they're still foreign bodies. And the body is expected to react to them, no? Because you want the body to react so that it induces or produces antibodies. So reactogenicity is, those physical manifestations. So if you inject, for example, on your shoulder or your deltoid, our immune cells will flock to that place where you injected it and start to produce some molecules that induce pain, swelling. Now, that's all expected. That's all part of the vaccine experience. Sometimes these molecules spill into the bloodstream, and that way it can cause fever, headache, fatigue. No, but these are all expected to be mild and self-limited, meaning they're expected to go away on their own. In most cases, paracetamol will take care of the headache or the fever or even the pain, and then it's gone. There's some reports out of the US where the second dose of the Pfizer vaccine or the Moderna vaccine can actually cause a slightly worse experience compared to the first. But then again, in most cases, these will go away on their own.
So how different are the vaccines in terms of efficacy, and how are they doing in the clinical trials?
We have been tracking the results of these vaccines. And in our talks among various groups, we make it a point to really delve deep into the details, but only on those with published phase 3 trials. We are eagerly waiting for the data from the other vaccines, but I think that we cannot make good conclusions about them without really knowing the exact details of the clinical trial. So the vaccines that we'll cover in the next couple of minutes will really be those with published phase 3 trials. The first one that I want to talk about is Pfizer. And in the phase 3 trial, they enrolled 43,448 patients, and then they randomized them. So that word randomization is important because it's really to make sure if you see an effect, then you can attribute it to the vaccine itself. So of the 43,000, they split that 1:1 into two groups, one to receive the vaccine, one to receive what's called a placebo. So a placebo is a substance that's designed to mimic the vaccine, pero walang active ingredient. In the vaccine group, they gave vaccine. In the placebo group, they gave saline, and then they let them live their lives. And then they counted the number of patients who developed COVID, symptomatic COVID. In the placebo group, 169 out of the 18,300 participants, 169 patients developed symptomatic COVID. In the vaccine group, out of the 18,500, only 9 developed symptomatic COVID. And there's a way to compute the vaccine efficacy that way, and the result is the Pfizer vaccine has a 95% efficacy. That's a really, really good number. There have been some serious adverse events that were reported, but these were very rare. Parang 4 lang so far. But it's also important to remember that these results are interim. The phase 3 trials are expected to run or to run its course for about 1 to 2 years. It's only after then that we will get the full picture. No? But so far, at the point of the data cutoff, this is what we're getting: 95% efficacy for Pfizer vaccine. It's also important to know that initially in the trials, they weren't seeing a lot of allergies. But when they rolled out the vaccines to the specified high-risk groups, healthcare workers, elderly, etc., they did see a lot more allergies. Not very, very common, but still high enough that they now added a statement: now, if you develop severe allergies after 1 dose, you shouldn't get the second dose anymore. And patients who have history of allergic reactions, I think, should do well to consult their doctor before they get the vaccine. The second vaccine is the Moderna vaccine, and this was developed in partnership with the US NIH. This trial enrolled 30,420 participants, about 15,000 in each group. Again, it's vaccine versus placebo. So the vaccine efficacy of Moderna is 94.1%. So very similar to the Pfizer vaccine. And the adverse event profile is also very similar. They also did report some adverse events, including some serious adverse events, but they were very rare. The Moderna vaccine also carries a contraindication for patients who get a severe allergic reaction to a previous Moderna dose. The third vaccine with a phase 3 publication is the AstraZeneca or University of Oxford vaccine. Actually, in the original trial, there were 5 sites, but in the interim report, they only looked at 2 sites, in the UK and in Brazil. It's about 7,500 in the UK, 4,000 in Brazil. The numbers that were being reported: 70.4% vaccine efficacy, and this was symptomatic COVID 14 days after the second dose. The safety profile is similar to the other vaccines, so really injection site pain, fatigue, headache, feverishness, and myalgia. Those are the main ones with phase 3 trials. The ones with the phase 2 studies, so Gamaleya, Sinovac, Novavax, and the other vaccines, from what we know, in their phase 2 data, so phase 2 studies only really look at seroconversion rates. If you get the vaccine, do you develop the antibodies? So for example, Gamaleya and Sinovac, the patients who received the vaccines, almost all of them developed the antibodies. But what we really need to find out is whether, when they're allowed to go and, do their thing in the world, are they going to be protected? So that's the importance of phase 3 trials. Vaccine efficacy, it's derived in the context of a very strict clinical trial, like a phase 3 trial. So these phase 3 trials, they have stringent criteria for who gets to be enrolled. Like I said earlier, for example, the Pfizer trial, they were very strict. It had to be healthy people, or if they had comorbidities or other medical problems, those medical problems needed to be controlled or stable. So they also avoided enrolling the very sick, the very elderly, cancer patients, for example. They didn't really enroll those patients. So it's a select group of relatively healthy people. And that's not real-world setting. So the number that you derive is in a way artificial. Okay, but that's the best way to really know whether the vaccine works. Now, once the vaccine is approved or receives an EUA, and it's rolled out, no? And people start to get the vaccine in real-world situations, no? Then that's when you can calculate the vaccine effectiveness. Vaccine effectiveness now takes into consideration, so the vaccine is given to the general population. There will be some who will get the first dose but not the second dose. There will be some who are elderly, have comorbid conditions that are not very well controlled. You now look at the real-world setting, and then you check how many people who got vaccinated developed COVID, for example. So very frequently, the number that you will get, the vaccine effectiveness, will be lower than vaccine efficacy because you lost that, that strict environment of a clinical trial.
Right. So how were the vaccines developed so fast?
All right. Again, a very important question because it's the source of a lot of concerns. No? It's important for us to realize that the process was not cut short. When a vaccine is developed, it usually takes years because the usual process is you do a phase 1 study with a handful of individuals, and then you just check to see if it's safe. You proceed with a phase 2 with more individuals, maybe dozens. You want to see if the vaccine is safe and if it produces antibodies. And then you do a phase 3 with thousands and thousands of individuals. And then it gets approved by the regulatory agencies, and then they do what's called phase 4 or post-marketing surveillance. So it's a long process usually, but this time, because we're in a very special, very unique situation, we're in a pandemic. Now we cannot afford to spend months and months doing, say, phase 1 and phase 2 and then only do phase 3. So what these companies did was to take a gamble. They did phase 1 and phase 2 together, for example, or they did phase 1 and then they did phase 2 and 3 together. So parang sabay-sabay na siya na ginagawa, but they still did the phase 1, the phase 2, the phase 3. But again, when we evaluate vaccines before they're rolled out, it's the phase 3 that we're looking at. The process was not cut short, but it was accelerated.
Having said that, so can you explain emergency use authorization?
Now, because we're in a pandemic, accelerated nga yung evaluation. No? The phase 3 trials are not yet done. The data that we're looking at, they're interim analysis. And the interim analysis show that these vaccines are very safe and very efficacious. So in order to immediately protect those who are at highest risk, meaning the frontline healthcare workers, the elderly, and even the frontliners that are not healthcare workers, our teachers, policemen, etc. In order to immediately grant or give them protection, the instrument there is what's called an emergency use authorization. The FDA has granted like a limited approval, kumbaga. So the emergency use authorization is granted not to the manufacturer, but to the government. The government now is allowed to use the vaccine in a limited manner to be given to a subset of patients. No? So in this case, the EUA is limited to frontline personnel, healthcare workers, the elderly, and the government has a list of priority groups. Okay, so as long as the vaccine is under an EUA only, it will not be given to the general population. Nobody can buy it in pharmacies just yet. Everything has to come from the government and from other agencies that the government delegates to distribute the vaccines. For example, hospitals will eventually be sort of delegated by the government to administer the vaccines because they need help rolling it out. But the main agency responsible for the vaccines, for side effects that the vaccines cause, etc., for monitoring, is the government.
So we move on to the facts versus fears segment of this podcast, where we share with you some of the sentiments of people about the vaccination and you comment on them. First comment. So I am already observing the safety protocols like washing my hands or observing safe distance. So I'm okay. I don't need the vaccine.
Getting the vaccine, at the bottom line, is a personal decision. Nobody can force you to get the vaccine, okay? But what we're urging is for people to do in their heads a risk-benefit analysis, okay? If you are a frontline healthcare worker, for example, and you are at high risk for getting COVID, then in my personal analysis, that's a weighty benefit, versus the risk of you getting COVID. The vaccine will not only benefit you, but it will benefit the people around you. No, it will not only benefit the people around you. If enough people get vaccinated, we might be able to achieve herd immunity that way.
I will just wait for herd immunity.
You will, okay. In order to achieve herd immunity, I have a good illustration. In this community that's represented in the panels, none have ever encountered COVID, so they are all susceptible. Enter this one patient who's sick with COVID. Because the immune system of these people have not encountered COVID before, they can easily get the infection. So this red person who's sick with COVID will successfully transmit the virus to, say, 4 other people. And then these 4 other people will be able to successfully transmit the infection to 4 other people. By the third panel, almost all of the population got sick. Except for the ones who got sick earlier, they've started to recover. No? Now, if the infection is a mild, benign disease, then that's not really much of a problem. The problem is if you have a condition like COVID, where it can kill people. No? It can kill the elderly when they get sick. So if in this situation, you can get a lot of deaths by this model, if you want to achieve herd immunity that way. In the next panel, you begin with a community where a lot of people have already either gotten sick or have been immunized with the vaccine. So if a patient or if a person who's infected enters that community, it's more difficult now to successfully transmit the infection. And because it's more difficult to transmit the infection to others, the people in the community that for one reason or another cannot get the vaccine. For example, they are allergic to the vaccine, or they are very immunocompromised that they can't get the vaccine. They will be indirectly protected because a lot of the people in the community are already protected as well. That's herd immunity. Now, there's a very high number that you need to reach to get herd immunity, and it has something to do with a concept called the R0. The estimation at this time is COVID has an R0 of maybe 2.5 to 3. To make it simpler, in a country with, say, 100 million tayo, diba? 100 million, you need to vaccinate 2/3 of those, or 2/3 need to get sick in order to achieve herd immunity. So the fastest way and the safest way to reach herd immunity is to vaccinate. Now, there's another critical assumption with that herd immunity model. It assumes that patients who get vaccinated do not transmit. So we need first to make sure that the vaccines also protect people or stop people from transmitting. And none of the vaccines at this time have proven that yet. And this is the reason why, despite the vaccines, we continue to recommend practicing minimum public health standards. No? So you need to mask up pa rin, physical distancing and hand hygiene pa rin, and face shields pa rin, no? To make sure that in the event na asymptomatic ka pala, even if you've received the vaccine, you don't pass it on to others.
We are still learning from Dengvaxia, so there must be safeguards in place to make sure that this vaccine is not as harmful.
To be fair, Dengvaxia, the vaccine itself, was effective. No? It's just that there was a critical requirement that was forgotten, meaning we needed to screen patients first for previous dengue. If nagkaroon na ng dengue, pwedeng magpabakuna. No? That should have been made clear from the beginning. I think now we've learned our lesson. We are studying the trials very well, and we know the safety profile of these vaccines, at least the interim analysis. And more importantly, the government is putting in place an adverse event following immunization committee. No? There's a national committee, and then there's going to be regional committee. So the surveillance for side effects is going to be better this time. We really need to try and make sure that the vaccines are not politicized or demonized. No? They have been shown to work very well. They're all going to work. They're all going to protect you from COVID. So we ensure that people are confident that these vaccines are safe. And the main way to do that is to start with the healthcare workers and, get them to believe in these vaccines.
Will I still feel the side effects of the vaccine 2 years after I get vaccinated?
In a great majority of cases, no, the side effects of vaccines will come out early. No, because the most common side effects of vaccines have to do with allergic reactions, the reactogenicity, etc. Some vaccines are known to cause rarer problems like Guillain-Barré syndrome. No? Some vaccines have been associated with Bell's palsy, but these are very rare conditions, and usually they appear almost immediately after the vaccines are given. So we do not expect long-term effects from the vaccines. However, we do need to realize that the phase 3 trials are young. No? They're not completed yet. So it's only really after the phase 3 trials are completed when we get the full picture of the side effect profile.
I have comorbidities, so the vaccine really isn't for me.
Well, again, that's a personal decision. They didn't really look at, say, pregnant women in the phase 3 trials. No? So we cannot definitively say na you should get it or you should not get it. I do know that there were some healthcare workers in the States who, despite being pregnant, received the vaccine. In their analysis, again, we go back to risk-benefit analysis. In their analysis, the risk of the vaccine is much, much smaller for them, even if they were pregnant, compared to the benefit that they will get from the protection of the vaccine. The same goes for comorbidities. No? So if you're hypertensive or diabetic, in fact, for these people, because they are considered vulnerable, getting COVID is actually very dangerous for them. No? So we do recommend that they get the vaccine despite their comorbidities, because the benefit will actually be much greater for them, no, compared to when they get sick with COVID.
There are no clinical trials done yet for my race. Most of the clinical trials were done in the US or the UK.
So it is true that most of the trials were done in the US and Western countries. No? But race should not be an issue because our immune systems will work the same way. And the expectation is whether you're black or you're of Chinese descent, it will work the same way. Okay, the first thing that needs to be said is the decision to get vaccinated is yours and yours alone. Nobody can force you to get vaccinated, okay? But in making that decision, I think you need to consider maybe two things off the top of my head. No? The first one is a risk-benefit assessment. With any medicine, whether it's paracetamol or an antibiotic, there will be side effects. Paracetamol, for example, can cause liver failure in someone who takes tons and tons of it. Parang ganon. So the side effect profile is there. But we always go back to the risk-benefit assessment. You weigh the risk of getting that product versus the benefit that you will get from getting that product, from taking that product. If you get the vaccine, there's that very rare chance of you developing a side effect as the risk. But the benefit is it will protect you from such a deadly disease. But not only will it protect you, but in a way, you indirectly protect the people around you, especially if you are a healthcare worker. Some might argue, and we've talked about this, I'll just do minimum public health standards. What if it fails? And we've had some people in the hospital swear that there was no break in their mask wearing and face shields, and yet they got COVID. So we go back also to that Swiss cheese model. Swiss cheese, they have holes, and these holes don't all line up. We think of protecting ourselves from COVID that way. The virus cannot penetrate through to the other side if the holes don't all line up. So these various layers of protection all prevent you from getting infected. And at the very end of this cartoon are vaccines, because it's the last layer of protection that someone can take on. No? In our analysis, in my analysis, the benefit that you will get from getting a product that's safe and very efficacious, far outweighs the risk that the vaccine may or may not bring.
And the most important question, after I get vaccinated, when can I go to the beach?
When can you go to the beach? Okay, in the initial rollout of the vaccine program of the government, we're only going to be able to vaccinate a small segment of the population. Remember, we're under an EUA, okay? So not everyone will get vaccinated yet. So the healthcare workers will be vaccinated first, etc. They will be protected. But remember, we're also not sure about forward transmission or onward transmission. So we're going to be wearing masks for quite a while, until the phase 3 trials are over, etc. But I think that even now, there are ways to resume some semblance of activity and normalcy by making sure that you observe the minimum public health standards. We now see people who go to the beach and they go with their families, meaning they're in the same household, and they eat. It's going to be open air. So parang the risk going to the beach is maybe lower. But we always just need to be very mindful about observing the minimum public health standards, especially when we're in closed areas, etc. But I think slowly, if we're very mindful of the safety measures that we need to observe, I think we can slowly start to do some of the things that we have done before. But there always has to be a think about how to keep it safe.
How about you, Dr. Carl? What's the pre-COVID activity that you miss the most?
Travel. I really miss traveling. I look forward to riding a plane again and visiting a different country. So that's the one thing that I really am looking forward to.
To get a COVID vaccine or not, that really is a personal decision. Maybe you've been reading comments in social media or been hearing from friends and relatives making you wary to get vaccinated. If lies and myths about vaccines spread so much that many people decide not to get vaccinated, more people could die and the pandemic will last longer. It's important to fact check with reputable sources of information and share good information with others. Like Doc Carl, we are missing a lot of things we used to do, even people who are most dear to us because of the quarantine measures and restrictions. We've been waiting for the vaccine since day one of the pandemic. Now it's almost here and we have to decide to get vaccinated or not. That is, of course, a personal decision. We all want things to go back to normal quickly, but what most of us have probably not yet realized, yet soon will, is that things won't go back to normal after a few months or probably after a couple of years, even with the presence of the vaccines. But remember, the first step to regain a sense of normalcy and for the government and the healthcare system to bounce back is for as many people as possible to get the vaccines to put an end to the pandemic. Email us here at Documentaries for any questions about this topic or any other suggestions for the next episode.